Hi everyone. Today we are going to see about central hypernatremia post neurosurgeries. So this is a cohort of surgeries which Dr. R.K. sir and Dr. S.V.K. sir did from 2003 to 2025 in Neuro 1 Hospital, Trichy, and it's roughly about 29 surgeries involving the suprasellar region, that is excision of craniopharyngioma. We had totally 8 patients, out of which 2 died, and we had 9 pituitary macroadenoma excision, out of which 1 death happened, and we had suprasellar germinoma, Rathke's cleft cyst excision, acom aneurysm clipping, and frontocallosal glioblastoma, and excision of tuberculoma celle meningioma. These are all the surgeries which are very close to the suprasellar region, close to the hypothalamus, and all these patients had central hypernatremia, but not exactly all the death was related to central hypernatremia, but out of 29 cases we had 6 deaths. So we are going to dwell deep into central hypernatremia. So why is it important, central hypernatremia? Because if you don't promptly diagnose central hypernatremia post neurosurgeries, like we discussed, pituitary tumors, 8 to 30% can have hypernatremia, and also most common in craniopharyngioma and Rathke's cleft cyst excision. If you don't diagnose that, then the patient can have severe dehydration, electrolyte imbalance, seizure. So that's the importance. And there are 2 types in central hypernatremia. It could be either a hypothalamic hypernatremia or diabetes insipidus. In diabetes insipidus, the urine output will be more than 200 ml per hour or 10 liters per day. But our focus today will be more on hypothalamic hypernatremia. It could be either symptomatic or asymptomatic. So first of all, the mechanism, what happens is hypothalamus stimulates the posterior pituitary to release antidiuretic hormone, which is otherwise vasopressin, and vasopressin will work on the blood vessel to increase the vascular resistance and increase the arterial pressure, and it also works on the kidney. Whereas in these situations where the patient has undergone manipulation of the hypothalamus post surgery, there is resetting of the hypothalamic osmostat. Normally, the hypothalamus maintains the plasma osmolality around 275 by triggering thirst and releasing ADH. After manipulation, the ADH release is affected. So what happens is post-surgical resection of a pituitary tumor, for example, that's the place where the ADH is released. So ADH will be reduced. So, and because of antidiuretic hormone reduction, there will be increase in urine output, which leads to hypernatremia. And the treatment will obviously be replacing the reduction of ADH, which is by giving subcutaneous vasopressin or in nasal desmopressin once the nasal pack is removed. So these are all the cases which we had in our hospital. This is a suprasellar tumor, which is a giant pituitary adenoma, which you can see here, and this first one is the frontal callosal glioma, and the second one is a suprasellar craniopharyngioma. And coming to the main focus of today, which is adipsic hypernatremia. Adipsia means impaired thirst. So this is the other name for hypothalamic dysfunction leading to hypernatremia. When the hypothalamus is not working, there is impaired thirst, that is adipsia, leading to ADH deficiency. So the patient will have no thirst, and the key diagnostic criteria will be sodium will be high, but urine output may be either low or normal. But in central diabetes insipidus, urine output should be high. So that's how we differentiate between central diabetes insipidus and adipsic hypernatremia. Sodium will be in central diabetes insipidus, sodium will be high or normal. So central diabetes insipidus is because of deficient ADH production, and the patient will have polydipsia and polyuria. Coming to the treatment, when the patient has adipsic hypernatremia, first of all, we should correct the sodium. If the sodium has been high for more than 24 hours, which is chronic hypernatremia, you should not reduce the sodium by more than 10 millimole per liter in one day, because it can lead to cerebral edema, seizures, and neurological damage. During sodium correction, you should also concentrate on calcium correction and potassium correction, because hypokalemia and hypercalcemia can worsen hypernatremia. And so this is for sodium correction. And when the sodium is high, you can give 5D with 5 units of atrapid in order to prevent hyperglycemia, or you can give half NS until the sodium is resolved to 135 range, and once the sodium has come to normal, you can give NS. And during this hypernatremic phase, you can give free water via Ryle's tube, which is roughly 100 ml per hour. And that's the same for central diabetes insipidus also. But the main difference between these two is vasopressin. Vasopressin is important in central diabetes insipidus because obviously the urine output will be more. So when you give vasopressin, it will help to reduce the urine output. You can give vasopressin 40 units subcutaneous as and when the urine output is more than 250 ml per hour in adipsic hypernatremia. And if it's confirmed central diabetes insipidus with the increased urine output, you can give it as daily 1 dose. After 5 days of removing the nasal pack, you can shift to desmopressin nasal puff BD. Okay, so one important complication which we should worry about is hypothalamic dysfunction post these surgeries, where the patient can have autonomic dysfunction, where the sodium is very difficult to correct. It goes into hypernatremia, then hyponatremia, and there is impaired thermoregulation with persistent fever because of this hypothalamic dysfunction, and there is bradycardia and panhypopituitarism, which we should be cautious about. So thanks for listening.